So first to say I'm a local lad. I went to Beaver Road School in Didbury, you may have heard it, and in Manchester Grammar. Did my medical degree in Bristol. Did various junior doctor jobs, and then came back to Manchester. Worked at Christie Hospital for a year, and perhaps because I wanted to find a way of helping the immune system combat cancer, perhaps why I ended up spending 4 years as a clinical immunologist, specializing in allergies, immune deficiencies, and autoimmune diseases. But I didn't really like having to look after the laboratory. I like looking after patients, but not looking after the laboratory. Ended up training as a GP after doing a few more junior doctor jobs. And I've been a GP since, mainly out of hours, since 2005. And for the last 4 years, I've also cared for my elderly father who has severe dementia, which might be the subject of another talk, perhaps. Well, as to how I cope with that and how I'm even here. And the next slide. So what is sepsis? There's all sorts of long, complicated definitions. But as an immunologist, to me, it's just when an infection gets the upper hand. And as part of that process, there's a huge inflammatory response. And every individual will have a different inflammatory response to a different bacteria. So there are thousands of different inflammatory molecules and proteins we all produce. Each one of us, we're all different in the amount that we produce. And that battle often occurs on the lining of our blood vessels. Okay, so we think of the lining of our skin, it might be just a couple of meters squared. The lining of our blood vessels inside our body has been estimated to have a surface area of the equivalent of about 4 tennis courts. So if you imagine, if those blood vessels become inflamed, you've got the equivalent of 4 tennis courts worth of inflammation going on inside your body. Hence why you end up with multi-organ failure, the clotting cascade going crazy, disseminated intravascular coagulation, all sorts of horrendous things can happen. So we want to try and diagnose it early. Next slide. And I'm not going to blind you with numbers because I can never remember them, but the one figure that I never forget is that each hour in the UK, five people die from sepsis. And I find that hard to forget. But wouldn't it be lovely if we could at least drop that down as 4? Still be terrible, but one little change could make that number into 4. And the UK Sepsis Trust have some advice for the public themselves, how you might go about improving that number. Sadly, though, the things they advise you to do are all quite non-specific. So you could have slurred speech or confusion for a variety of causes. It doesn't have to be sepsis. Flu can give you shivering and muscle pain. You might not have passed urine because you're not drunk, or you've got viral gastroenteritis and been vomiting and had diarrhea. You might be breathless because you're having a panic attack and have asthma. The feeling of you going to die, well, a panic attack can sometimes just give you that feeling. Having mottled or discolored skin, that's the type of rash that you might get taught to do the glass test, or you stretch the skin, and it will leave a permanent dark mark. And doctors will also look for maybe lines on fingernails and soft palates and even back to your eyes for those kind of lesions. And the advice gets even more confusing for children, it gets even more complicated. So you'd be doing well if you remember all that, and you'd almost be sending every sick child to hospital if you followed that advice. Once you get to hospital, the Sepsis Trust would like doctors, health professionals, of course, to follow these 6 processes to try and save your life. Ideally done within an hour. So they like blood cultures to grow what kind of bacteria is causing the sepsis, because obviously you want to find out which antibiotic will kill it best. A full blood count, because very quickly you get white blood cells released from the bone marrow. Sadly, that's quite non-specific, so any stress response will cause that. Even a heart attack will cause those levels to go up. a lot of GPs will measure a protein called the C-reactive protein, which is produced by the liver, but that takes 3 days to get to a peak that value. The blood lactate, you've probably heard of lactic acid. You overexercise, you get lactic acid in your muscles. Lactate gets formed from lactic acid, and in hospitals, they'll measure that in your blood. And if the level is above 4, sadly, people have a 40% chance of dying. Giving fluids. But the key thing on this slide is that those that have a low blood pressure who all have sepsis and are also shocked, and that's the low blood pressure when they're lying flat. For each hour of delay of antibiotics, they have an 8% increased chance of dying. So can you imagine if we were able to diagnose it a day earlier, how much greater their chance of surviving would be? So as a GP, I don't have access to this machine. But I thought to myself, well, I Googled, is there a machine, a bit like one where a GP would check your blood sugar, that would check lactate as they do in hospital, and actually one exists. And I don't think that's expensive, but of course it still needs to go through a proper trial. And you could argue that perhaps a very, very raised lactate level is still a very late sign of sepsis. And once you've got that degree of acidity in your blood, the patient will look unwell, and they'll also be breathing very fast and very deeply. Because when your blood becomes acidic, you try and breathe out carbon dioxide to get rid of that acidity. I'm tempted to buy one myself, actually, just for me, but anyway. So GPs, hospitals. Oh, we could try the occasional one. Yeah. But in the concept, when you're thinking of diagnosing sepsis early, yes, there are hundreds of tests you can do using on a drop of blood. Yeah, we do it all the time, checking people's glucose. It's a simple place. There's no need, because that test is effectively the same thing, and it's but yeah, I'd rather use the machine because it's quite quick and easy. But you're right, there might be some kind of strip test that doesn't require a machine. Just has a simple color change, a bit like the COVID test, where you're just looking for a line, and might only be a pound of test and doesn't then require a machine. So you're right, yeah, there might be. I haven't Googled that. So yeah, it's a good point. So the NEWS2 score, the National Early Warning Score, is what all hospitals and paramedics use, and what they would all like GPs to all use. And every time I ring an ambulance to admit a patient to hospital, the ambulance, the operator will always ask me the NEWS2 score for the patient, although it's not always possible to give them one. It's NEWS2 because nowadays we have 2 scales for the oxygen. So basically, on the left, you see all the parameters that we have to measure, and each one has a normal value, which is where you'd have a score of 0. And then they have different scores depending on how abnormal those other parameters are. And if one of those parameters scores 3, that is considered a trigger sepsis. If the total for all the parameters is 5 or more, that's also considered a trigger sepsis. And if you get admitted to hospital, there will be something called tracking. So you'll have a NEWS2 chart at the end of your bed, and every day the nurse will check all these readings, and they'll track your score. Now, respiratory rate at the top, that's just respiratory rate and not depth of breathing. Remember I said if someone's blood is acidic and they've got sepsis, they'll breathe not only faster, but more deeply. So we call that Cushional breathing. But it's hard to assess the more depth of breathing. But as a clinician, that's something that I would be watching for as well. Oxygen level, well, you could just have pneumonia, and it's a very late stage to actually get so much blood leaking through the blood vessels in your lungs because of sepsis that you'll start being short of breath. I forgot to mention that all those blood vessels, once they're inflamed, they become leaky. So you start leaking fluid out of all that 4 tennis courts worth of surface area of blood vessels into your tissue. It doesn't take for them to be very leaky, as you can imagine, with that sort of surface area. The bottom conscious level takes a lot to start making. Well, I don't know. People can be mildly confused with a simple urine infection, I suppose. But temperature is quite non-specific. So because most people with a very raised temperature have got a viral infection and not sepsis. And also in late sepsis, the body becomes unable to generate temperature. Become too unwell to generate a temperature. And someone who's immune suppressed, say on chemotherapy, or they have a hereditary immune problem, can often are unable to make that temperature. And sadly, even doctors, they forget that to look and realize someone's immune suppressed and they could still have sepsis even though their temperature is normal. But I'll really point to the subject of today's talk, which is the blood pressure and the heart rate. So they focus on the systolic blood pressure. When you have your blood pressure taken, you get 2 readings, the systolic and the diastolic. The systolic is the higher reading when your heart contracts, and the diastolic is when your heart relaxes. And quite rightly, in my view, they're focusing on just the systolic, and that's what we'll be doing today. And the pulse rate. But sadly, they allow everyone in the country to measure those readings when you're lying down. When it takes you to have very, very severe sepsis before those start to be affected when you're lying down. You've probably heard of septic shock. You lie them down. If you stand them up, of course, their blood pressure drops. So they are missing an opportunity to diagnose things at an earlier stage, in my view, by allowing everyone to just use lying readings. Next slide. So not going to spend long on this. So this is a horrible slide that most GPs are told to try and learn and use and put into practice. It's the traffic-like system. The British Medical Journal criticizes it. Everyone criticizes it because if you followed this, you're sending nearly every sick child to hospital. I've only put it up there to point out that there's nothing on that chart that has anything to do with a change of posture. And yet we all know if someone can go pale in the face if their blood pressure becomes low when they stand up. You notice that change in color. There's no suggestion of watching out for a change of conscious level. I once had for a baby lying in mum's arms, completely alert. The moment mum changed the posture of that baby, the baby became unconscious and started to fit. I then just asked mum to lie the baby down, and baby woke up again. And we were able then to rush the baby to the pediatricians, and baby's just fine. But in my training, I'm not taught to watch out for that. I just, because I'm so interested in blood pressure, the very fact it even occurred to me to tell mum to lie the baby down again isn't even taught. Change in heart rate. So children are amazing. They have amazing young hearts. So they can generate huge high heart rates to stop their blood pressure falling. So in children, I think a change in heart rate is even more important than change in blood pressure. And of course, if I had one of those lactate machines, I could do a little heel prick, take a little drop of blood, check child's lactate level. So that would be pretty useful too. So what happens when we go from lying to standing? And I've deliberately made this non-medical with just 4 pictures that hopefully you will remember. So imagine this rusty old water pump, but it's still working pretty well. It's 80 years old. It's still doing a pretty good job, but it can't go at 200 200 pumps per minute anymore because it's a bit rusty. It's not as well maintained, but it's still pretty good. And these this hose pipe, which represents your blood vessel. Sadly, this hose pipe is a bit further up inside, so it can't constrict quite so well. Because when you stand up, those blood vessels need to constrict to stop all our blood going down to our legs. Okay, so not only when we stand up, not only does the heart have to pump a bit faster, a bit more strongly with each beat, but the blood vessels, particularly in our lower limbs, have to contract. So that's two things to remember. The next two is a nervous system. So those power cables effectively represent your nervous system. So there are the receptors called baroreceptors. You've all heard of barometers. Basically, a baroreceptor checks the change of pressure in the blood vessels in your neck, in the upper chest, when you go from, say, lying to standing. And it will then send signals via a part of the nervous system called the autonomic nervous system. It's called autonomic because it's automatic. You don't have to think about it. When's the last time you thought, oh, so I've got to make sure my heart goes a bit faster or beats a bit more strongly? And there's two parts to that. There's the sympathetic, which is the bit that helps you your heart go faster and so on, and escape the saber-toothed tigers in ancient times. And there's the parasympathetic part of it, which is the bit that is more active when you're resting and digesting your food and you need to go to the toilet. And the two compete with each other. So if one's more active, the other's less active, and vice versa. And then, but the other thing about those power cables it's also reminds you of is you need a supply of energy. So your heart needs energy, your nervous system needs it, the blood vessels need energy to contract, got muscle inside the blood vessels. So if for some reason your energy supply is faulty, so poor oxygen supply, poor glucose supply, or the little mitochondrial bacteria, ancient bacteria inside every one of your cells that are little powerhouses that provide you with energy are dysfunctional for some reason, and there's lots of reasons why they can become dysfunctional, that can also cause a problem. And then you have to have enough fluid in your blood vessels. So you could have had bleeding, you could have been vomiting or had diarrhea, you could have not drunk much that day, or your kidneys might not be responding to a hormone that stops you from weeing excessively. Your blood glucose could be really high, which would drive your kidneys to produce more urine, or your GP could have given you some diuretic to make you wee out more fluid. You could be dehydrated because of that. So remember those four pictures. If you remember those four pictures, you can understand what a lot of medical professions find difficult. Because sadly, they get given a slide like this. Oh, wait a minute. So, before I get to that one, I'll say, so what I'm not going to be talking about today are reasons why you might have a simple faint. So 1 minute, a healthy person, completely well, but next minute, they fainted. They're the patients that I quite often talk to on the phone, try and work out, do I need to send them to hospital? Did they have a cardiac arrhythmia, something more serious? But normally, there's a group of, remember those four photos? So normally when someone has a faint, there'll be a combination of factors. They might have got too hot, so they're wearing a hot jumper on a hot day, so making the blood vessels in their arms and legs dilate, diverting blood to the skin away from the center of the body. They might have had a big meal, again, diverting blood to their digestive system away from the main blood vessels of their body. They might need to go to the toilet. They might have a full bladder, or they might need to open their bowel. That activates the parasympathetic nervous system. Remember how I said the two compete with each other? The parasympathetic, if you've got a full bladder, will actually lower your blood pressure, particularly when you stand up. It will stop your sympathetic nervous system, making your heart beat faster and more strongly. In fact, there's even a name for it, micturition syncope. Syncope is the posh word for passing out. micturition means going for a wee. And in my view, most of those, there's probably something else, like the patient was dehydrated, hadn't had a drink all day. And the other factor is pain or shock. That can also activate the parasympathetic nervous system. So nearly always, I'll find 4 factors in the history as a reason why someone's had their faint, and then I can reassure them. Of course, this is providing that they came around the instant they were lying down, they came around, and they were normal. Because of course, and what you don't want to do if you're feeling faint is carry on standing up, or you see someone who's feeling faint, just mop their brow and keep them standing up. You want to get them ideally lying down, help them take off that hot jumper, get them some water to correct those factors. Okay, so anyway, what do doctors try and diagnose? Well, there's a condition called orthostatic hypotension. The other name is postural, change in posture. Hypotension means low blood pressure. Orthostasis just means standing up. And doctors are told they can diagnose it if someone's systolic blood pressure falls by 20 or their diastolic falls by 10. 10 isn't much, is it? So, to my mind, that seems a ridiculously small amount. I'm not a fan of measuring diastolic blood pressures. And long-term studies show that people who have this are 1.5 times as likely to die. Yet we don't measure it, we don't screen for it, and in fact, if you Google it, you'll find it's associated with nearly every bad thing, which isn't surprising because if you imagine the person who might always drop their blood pressure when they stand up, could they have a poor heart? Are they someone who never drinks? So they go to bed dehydrated with sticky blood. They're the people who are going to have the heart attacks and the stroke in the night when their blood is sticky and not moving very well. So it's really important to keep well hydrated. And it's estimated about 1 in 5 adults over the age of 60 would have this. The sad thing is they ignore heart rate. So what happens is only old people get diagnosed with this because young people have such healthy hearts, they can raise their heart rate and they don't drop their blood pressure. So, and that's what makes it more difficult for doctors because they have to go by this definition and they're ignoring heart rate when the two are inextricably linked. Heart rate and blood pressure go together. Once the heart rate goes up, your blood pressure goes up. That's why if you see your GP and your blood pressure is through the roof, your GP can tell they need to give you time to relax because your heart rate's racing. The old white coat hypertension, and they can tell that because your heart rate's 30 more beats than it normally is. Okay, next slide. So yeah, more complicated slides to confuse doctors and make it even harder for them to know what to do or even want to do the test. You go back to those 4 pictures, though, you all now would do better than most doctors at understanding what's happening than people who have to go through a slide like that. In fact, there's a one thing in there that I actually think shouldn't be on there, and lots of ones that aren't on there that should be, like sepsis or anaphylactic. Severe allergic reaction to an allergen isn't on there. And then on the other end of the scale, doctors are told they can diagnose a condition when people stand up where people's heart rate shoots up. But, oh no, you don't measure their blood pressure, you just focus on the heart rate. So guess what? Young people get diagnosed with it. And I disagree with most of the diagnoses that are made with this because the normal physiological response when you stand up is for both your heart rate and your blood pressure to rise by about 10 to 15%. That isn't a normal response. So this condition is saying it's abnormal if your heart rate rises by more than 30. And one of the leading abnormalities they say is the cause is the problem with the autonomic nervous system. To my mind, that's not the problem. It means it's functioning better than it normally does because it has sensed the change in posture, told your heart to increase by a lot. It's actually telling you that it's working really well. The problem is that patients with it get worried about that increase in heart rate, start to worry about it, then they have the anxiety on top. And I think most of these patients just need to be reassured. Sadly, a lot of them end up with being given very powerful medications to stop their heart rate, increasing their heart, so their heart increasing the heart rate, and to stop their nervous system to detect those detecting those changes, when all they needed was reassurance. And in fact, you're not even allowed to make the diagnosis of blood pressure drop. So I think they should bin both of those and start looking at heart rate and blood pressure together. And the other reason why your doctor probably won't want to do it is because I was taught when I was a medical student, you've got to wait. If you stand someone up, you wait a minute before checking another reading, and then you wait another 3 minutes, and then maybe you wait 10 minutes to do the final reading. No one has that time. But thankfully, there has been a recent study that's shown to do it straight away. And that makes sense. Because what is the best test of normality? The ability of your nervous system to respond and detect the change in posture and tell your heart to quickly pump faster, more strongly, and to tell all your blood vessels to contract. The faster it can do that, the more normal. So it's no surprise doing it straight away without any delay, without waiting 10 minutes, is better. So there's no excuse. But very few people will have seen that study. And I'm not the only one getting frustrated. So this was a study looking, I forget which journal, nursing for older people. But they looked at 179 hospitals in the UK with almost 5,000 patients admitted to hospital with acute severe illness. They only included those that were capable of standing up, and they didn't look at heart rate. But at least they looked at blood pressure, so I won't tell them off too much. But what they looked at, so they, like me, feel that patients who run well should have one set of readings done, say, with them lying down, and another with them in a more upright posture. Obviously, you have to make sure it's safe for you to do that. So you might sit them up in bed first, maybe then sit them on the side of the bed, check another reading. It's still safe. You might get them to stand up, but holding on to them with someone else holding on to them. So if they do feel dizzy or faint, it's safe, because safety is paramount. They excluded bedbound patients. Can anyone think of a reason why you could still take blood pressure and heart rate readings in two postures in a bedbound patient without getting them to move? They could be unconscious. Can anyone think of a way in which to get exactly head down, tilt, head up, tilt? You've got your two readings. So I wrote a letter to the BMJ in the 90s. For 30 years I've been on this. After one of my patients died, because my entire team, I was a junior doctor then, my entire team didn't realize one of my patients was bleeding internally. And I remember thinking, so just let him die, young patient. And I remember thinking, why didn't we just tilt the bed? Okay, we didn't have anyone on the team that could put in the central line and check the pressure and check the central venous pressure. No one thought of doing a fluid challenge because we thought it was his heart. And the reason for the internal bleeding, no one could possibly have suspected. But if we had tilted the bed, his blood pressure would have gone up. And we might have had a clue anyway that he was bleeding. This emergency care consultant is just as frustrated as me when he tries to persuade his colleagues to check blood pressure readings and heart readings in different postures. What do they say? They say, I find it strange to hear such opposition, blah, blah, blah. but yeah, they basically disparage what he's saying. So orthostatic vital signs, just saying, checking your blood pressure and the heart rate in a different posture. And he actually tells them, well, okay, why do you check temperature then? If you're not going to check all the blood pressure and the heart rate when they stand up, why do you bother with temperature then? And he gets into arguments with them. And there is some reason why his colleagues don't want to do it. So, for instance, there was a study done on healthy blood donors. So people just given blood, half a litre of blood, and they looked for changes in blood pressure and heart rate, and they found that it was difficult to, it didn't detect all those. The changes in blood pressure and heart rate wouldn't have detected all those that had given blood. But some of them did have very high heart rate, and 98% of those that had a very high heart rate were the ones that had given blood. So, and also they didn't try and look at both at the same time. They just looked at one or the other. And I actually emailed the author today, unbelievably gave me an instant answer, because I wanted to do further analysis on his data. And sadly, he said that he was tired and didn't have any of the data left. So that was a bit sad. But and this website is one of the very few websites, an American site, that encourages people in hospital to at least measure changes in blood pressure and heart rate to prevent falls. But the time taken to do that, it's the waiting 10 minutes thing, doing it lots of different times. And because it's so time consuming, they have a whole list of who you should do it on, who's at risk of falls, rather than doing it on everyone and doing a quick version, as I think you should do. Oh yeah, that was the study on the blood donors. So I came up about 5 years ago with this acronym, ABCDS, for the conditions that I want to think about, that I don't want to miss when my patient drops their blood pressure when they stand up or their heart rate shoots up. So A, autonomic dysfunction. Remember that we talked about the autonomic nervous system. So someone who, say, had diabetes for 30 years, with poorly controlled and has damaged the nerves in their legs, will often also have damage to their autonomic nervous system. So it will be normal for them, perhaps, to have a drop in their blood pressure when they stand up. Completely normal. Would be nice to know what's normal for each individual person before they become unwell, because then you can compare it with that. So in my view, every GP in the country should have a baseline normal result for everyone. And then when you become unwell, my goodness, it's much worse than it normally is. And then the other one is anaphylaxis. So I was an immunologist or trainee registrar for 4 years. So I used to see lots of patients who had severe allergic reactions. And you get a release of histamine when you have a normal allergic reaction, and it dilates blood vessels, makes you flush, sends blood to your skin, makes those blood vessels unable to contract, so the hose pipe no longer squeeze, and then you end up with a very low blood pressure in anaphylaxis. No one has ever tried to diagnose it early by seeing if someone can't maintain a blood pressure when they stand up or their heart rate shoots up. That's never, ever been done. But the interesting thing was that when I had my first COVID jab, and please don't do what I did, because doctors are the worst possible patients. Doctors do not want to call 999. Doctors will not go to hospital because we're all more scared of hospital than you are. So when 6 hours after my first COVID jab, when I'm sat on the sofa and I say to my girlfriend, can't stand up, I'm really dizzy, can you get my blood pressure machine? I just need to check something. And then when I checked it, I found my heart rate was jumping up to 140 when I stood up, and my blood pressure was dropping. And I said to my girlfriend, okay, I'm just going to lie on the sofa for a bit. And my breathing's okay, so I haven't got that type of anaphylaxis. So I'm kind of thinking, okay, I remember from my training, my own body's going to produce enough adrenaline. Hopefully, at some point, I reckon I can get away with out having an EpiPen. Hopefully my body produced lots of steroids, so I can maybe get away without that too, because I'm scared to go to hospital. So I put my legs up on the side of the sofa and said to my girlfriend, if I lose consciousness, can you fall down a night? And about 2 hours later, I did lots of repeated measurements and my reading got better. And thankfully, I was okay. Probably the reason was it wasn't really anaphylaxis. There's a thing called anaphylactoid reaction, which is what you normally get in response to drugs and chemicals. And that's, you get different mediators, not necessarily histamine. It's a bit like if you've ever heard of angioedema, you might get a swollen face if you've eaten peanuts, but you can also get a swollen face if you are on a blood pressure medication called an ACE inhibitor. And that isn't caused by histamine, it's caused by bradykinin. I'm waffling now, but anyway, gone off track. B, bleeding. I've kind of covered bleeding a bit already. Cardiac dysfunction, that's your rough heart pump. What excites me about that is the chance to diagnose viral myocarditis in a young person. So viral myocarditis is, say when you have a flu, and that young person's heart has become attacked by the virus. There's no way your GP is going to pick that up until that person initially collapsed and they're on the way to hospital and ICU, in my view. But there was a case report where they picked it up because the person with it dropped their blood pressure every time they stood up. And in my view, even though those studies have been done, it might be a way to diagnose it. And I'll certainly be considering it. I'll still be worried about sepsis, mind you. Dehydration I've covered, and sepsis, there's more than one reason. Remember I mentioned how all the blood vessels become leaky with fluid leaking out of those vessels. The vessels become unable to contract as well. Got blood going down to your legs. Your heart becomes less able to pump. So multiple factors why sepsis would cause abnormal readings. No study has ever been done, ever, looking to try and diagnose sepsis early, see if someone drops their blood pressure when they stand up or raises their heart rate. And I find that shocking. And for over 25 years, I've been telling colleagues, so over 30 trainee GPs I've talked to, probably over 50 paramedics. In fact, the Northwest Ambulance Service wanted to start doing it, but said that I had to get a study done first until they were allowed to start doing it, allowed to measure someone's blood pressure and heart rate in a different posture. But thankfully, I can ask them over the phone. So when I do speak to them over the phone, they'll do it for me. And about 4 years ago, I came up with a way to, I don't need to use this because I'm used to interpreting the change in systolic blood pressure and the change in heart rate, those 4 numbers. But most people aren't. And it is complex. I'm not saying it's easy. So what if there was a way of converting those 4 numbers into 1 number? And there is. And what if that number was nearly always 1 in a healthy person? In fact, what if that normal response is both going up when you stand up in a really healthy person? That percentage increase in both the heart rate and the blood pressure kind of cancelled out, so you still ended up with a result of 1. So imagine, first of all, dividing the SBP is systolic blood pressure, in case anyone's wondering. LP is lowest posture. So imagine that first number, SBP, LP. Imagine it's someone's blood pressure when they're lying down, and imagine it's 120 solid. And then when they stand up, it drops to 100. 120 divided by 100 is 1.2. Now, if you imagine their heart rate in the high posture was 120 because it had jumped from 60 to 120. then we'd have 120, the heart rate bit, we'd have 120 divided by 60, which is 2. 2 times the 1.2 would be 2.4, a terrifying number in my view. And hopefully, now we're going to check Sarah's results. Hopefully, it won't be terrifying. So I'll need my glasses to record the numbers. But the blood is stuck as well. Right. So the figures shouldn't be affected. Right. But I'm going to do some other things. So obviously, if you guys did this and got an abnormal reading, you'd want to keep, because you seem to have abnormal results. I'm a bit lazy, so I like to make sure that my reading is accurate. So one thing I'll do is I'll try and feel the radial pulse at the same time. I've got nice radial pulse. So what I'm going to feel as the cuff inflates and deflates, I'm going to feel for when the pulse, not yet, disappears and appears. Hopefully my voice won't interfere with the machine, but hopefully the batteries work. So it disappeared about 108, and I'm going to see when it reappears. So it reappeared about 112. So I bet the machine will probably say about 115 if it's systolic. Let's see what it does say. Oh, what I didn't do, I should have put this on your other hand. Keep that still. Put this on here quickly. So it says, 125. So I was out by 10. You are supposed to add 10, but I like to think I'm too good at that. 125. Yeah, the systolic 125, and the heart rate was 79. Oh, you would. Oh, do you want to switch to the? Just note it down first. Oh yeah, okay, yeah. What I will do is I'll check your. So we can check the heart rate, make sure the machine gave an accurate heart rate.
Let's do it again.
No, because so this pulse oximeter checks oxygen level. It also checks heart rate. It's saying 85. It was 79 with the blood pressure machine. That's pretty similar. The other thing I was checking, was it a normal pulse? Was it regular, a normal pulse volume? Because if it was irregular with a variable volume, she might have had atrial fibrillation. And then the heart rate readings from this machine would be unreliable. And then the pulse oximeter would probably give me a more reliable heart rate reading, and I'd use that instead. But anyway, what we're doing now. So now we need to stand you up. You keep that on. You're standing up. I'll hold on to that.
All right, okay.
And pop that there. Of course, I would normally be holding on to you to make sure you don't fall over. My assistant would be over there as well to stop you falling that way, keeping it completely safe. They normally have a relative on the other side. Okay, so let's have a go. Whoops. So again, I'm going to estimate with systolic. I don't get much time at the cuff inflates. It inflates quite fast. 110 maybe. Now I deflate slowly, so I get another chance. No. It was only about 100 coming down. So it might have dropped a bit. It's safe. Anyway, what it said. Oh, I'm wrong. 121. 121, the solid, and the pulse 112. Yep. And the oxygen saturation 104. So yeah, pretty similar. I wouldn't normally do this. I'm just showing you. There is another reason. If the blood pressure was really, really low, everything had dropped to less than 70 or 80. This would find it very difficult giving an accurate heart rate reading. In fact, one of the cases I'll show, I think, looking back, I think it's given the wrong reading. One of my patients. Yeah.
And do certain birth effects, especially effects to reduce blood pressure. Do they have any effect between these two readings?
Right, say that again.
Do certain vector affect this, such as effects for reducing blood pressure, hypertension effects? Do they affect this? Medication.
Yeah, so beta blockers, for instance, would prevent you from generating an increased heart rate.
Yeah.
So lots of medications could potentially cause this, particularly diuretics, which will make you urinate a lot. And sadly, a lot of people put on diuretics just because they've got swollen ankles, when often that's not necessarily due to heart failure. Normally, it's just due to venous insufficiency. The veins in the lower leg have become a bit incompetent. You get swollen legs, and actually, what the patient really needed was just to elevate their legs higher than the level of their heart for a few hours every day, rather than being given drugs that dehydrate them and then make their blood sticky.
Yeah. So that's something that should be taken into account, and it's another factor.
Sorry,
that should be taken into account as well as the other factors.
Yeah.
Do you want to go roll?
Yeah. So there's the check. Most the links up right. That was it. The first one was 5 and you got it perfect. 1, 2, 1, 112. So drum roll. So you get down.
Down. There.
So it's 5.4. So we. So bear in mind though, we're in a hot. Because it's hot, all the blood vessels are dilated. Also alcohol dilates blood. All right. Okay. So what we might do then do it again. because we can't leave it at that, because that's too abnormal score, too high. Say that we'll do it again. So maybe the chip cells in the minute. So do I look back 75 6 month period? I would say blood pressure and heart rate. And these are the changes in posture. And most of the time, either I couldn't be bothered to get the patient to lie down or didn't know where to lie them down, and I just did a sitting to standing. Even though lying to standing would be the most sensitive test. This is the greatest change in posture. Okay. And so 15 of those were calls to paramedics. So paramedics normally only want to speak to a GP like me, either when they're trying to persuade the patient to go to hospital and the patient is refusing, which luckily was a non-those cases. The chemical can take a while sometimes in those cases. In all these cases, they thought the patient wasn't so unwell that they needed to go to hospital. And these were their ABCDS scores. And only one person had a score above 1.3. So that would have been you. But that patient had been vomiting and had diarrhea for quite a few days and was really dehydrated. And we still didn't admit them to hospital, but with that knowledge, I made sure they got medication to stop them from vomiting, and that they knew that if they failed to get enough fluids in, they would still need to go to hospital for intravenous fluids to stop their kidneys from being damaged. Okay, so, and the other 60, they were more, the ones that I had to see myself, they were more unwell, because a lot of them would visit the people. And when people are really unwell, the last thing they want to do is to go to hospital, because they feel too unwell to go to hospital, so they call a GP instead. And quite a few of those had high results. The ones more than 1.3, if say they had a urine infection, I was always more likely to give them perhaps maybe a bit of a longer course of antibiotics, maybe a slightly more powerful antibiotic. So I must admit, I would often, even with no evidence, I couldn't help but perhaps be swayed by the results. And that's why we need studies. We need studies to see whether this can be useful. And I'll now tell you a little bit about the 3 patients that had a value more than 1.6. So sadly, all 3 died before I was able to get written consent to tell you all their details. What I will do is try and avoid saying their gender, their age, and any specific diagnoses. I'm deliberately going to be really vague with their diagnoses. But I still feel that if they were alive today, they would want me to be telling you all about it to try and stop others from being in the same situation.
Can I ask a question, or do you want to hold it to the end? You've got a question from somebody online.
Can we? Because we're not far from the end. I've only got 4 cases, and then a final summary slide. So the first patient was a telephone call, and they'd only been discharged from hospital the day before, following an episode of sepsis. So straight away, you've got someone unwell that is worried they've got sepsis back again. And I'm worried about it straight away within the first few seconds too. So when I asked them over the phone to give me some readings, you can see the lying blood pressure, 112, was actually normal. Rather, when I say normal, it would not have elevated the News 2 score. Remember the scoring slide of the News 2 scoring system? Nor with the heart rate. Lying heart rate, 66. Their oxygen level was low though, so that would have been a trigger for sepsis by itself. But suppose they hadn't had that available, then all they would have told me was the blood pressure readings, which was normal. But when I got them to sit up in bed, the systolic blood pressure dropped by 30, despite the pulse more than doubling. Which, if you calculated a News 2 score with those readings, you'd get a value of 8, well over the threshold for sepsis, or the trigger for sepsis. And the ABCDS score would have been a horrifying 2.8. Sadly, I've no idea what happened when they got to hospital, because I was never able to get the consent to find out. And it would be lovely to know what was done. Did they check their lying blood pressure and heart rate, and then they weren't worried? Because that oxygen saturation might not have been a genuine reading, because the person that told me that over the phone might have had a faulty device, and it could actually have been normal. Patient B, again, telephone call, just to a carer. The only information I could get was, fortunately, they had a blood pressure machine. The history, they had a source of bleeding that often causes infections. That's all I'm going to say. And they also had an immune problem that I didn't realize, even though I was an immunologist, I didn't realize it was actually an immune problem at the time, because they misspelt it. And I think on their records, it was probably misspelled. It was only after I realised that there was one letter difference in it. I can't say more than that because I can't. It might be too identifiable. But their systolic blood pressure dropped from 150 to 111, sorry, when they stood up, despite, again, the heart rate going from 72 to 98. And I did it again, so it was repeatable, because I'm going to call an ambulance. I'm not going to do it on the basis of one reading. I won't do it on the basis of one reading on Sarah. I'll do it again. And hopefully we'll get a normal reading after. This patient, and again, I don't know what happened to them. All I know is they passed away by the time I tried to get permission to publish their details and be able to tell people in detail about their case. Patient C, I did get a verbal consent because this patient survived their initial contact. So, and I spoke to the patient over the phone, and they told me what had happened. So there's a patient that had an operation a few weeks beforehand and was actually on antibiotics already. She had already started antibiotics for a wound infection related to that operation. The patient felt unwell, but not really well. And the temperature was only 37.5. And the sitting blood pressure, 128, completely normal. The heart rate was raised to 100. And a heart rate of 100 when you're just sitting down, that when they're not anxious, was a bit of a red flag. And when I stood up the patient, their blood pressure dropped, and despite the heart rate increasing further. So I thought, oh, I'll do a lying to standing one just to confirm this. And again, I got similar big changes. And the patient's ABCDF scores were 1.6 and 1.8. And I sent him to hospital purely on the basis of this, even though he was already on antibiotics, didn't look unwell. I couldn't fight. Yes, there was a slightly smelly wound, but the patient was already on antibiotics. It's been started by patient GP. Why would I do anything else? I would normally say, have a bit more time on the antibiotics, but I called an ambulance, send them to hospital, and probably not unsurprisingly, they just sent them straight home. And then a few days later, they had to readmit the patient, have an operation to drain an internal collection of infection, and they needed about 6 weeks of intravenous antibiotics. And their microbiologist told me the names of all of them, and I hadn't heard of them. Weird and wonderful antibiotics. And the patient survived. They would talk to the patient, but I was too lazy to go around to their house to get the written consent, sadly. Patient D didn't have a very high ABCS score. And I think, so this is a patient that I saw face to face, had a problem that can affect your immune system, that's all I'm going to say, and had a very high temperature. But even with that high temperature, and even with a resting pulse rate of 125 when they're lying down, the needs 2 score would only been 3 and would not have triggered concern for sepsis. When I sat the patient up in bed, the blood pressure dropped to 74. The heart rate, really weirdly, and I only recently worked this one out, really weirdly dropped too. Which doesn't make any sense, does it? Because the heart rate's supposed to go up, isn't it? And I realized if you've got the blood pressure of 74, that machine is not going to pick up all those heartbeats. It's going to give you an abnormally low reading. And that's why I think if any studies are done, they need to be aware of that. So that if someone has a really low blood pressure at any point, maybe need another way of checking the heart rate, like the pulse oximeter, listening to the heart, and so on.
Question. Is there any way of using either direct measurements or proxy using smart watches or something like that to do continuous monitoring whilst either in a hospital or home environment?
Yeah, we'll continue. Heart rate monitors do it all the time.
Yeah,
but to get continuous blood pressure monitor, you can still blow up. You can have a wrist cuff, more convenient for some people. Easier to put on than struggling with a upper arm cuff. So actually the true ABCDS score is probably much higher. And if we just took a ratio of the two blood pressures and assumed that the heart rate hadn't changed, actually that ABCDS score would probably have been as high as those first three. So my final slide is kind of a reminder about the calculator. And also the first line, so I spoke to Ron Daniel, who's the director of the UK Sepsis Trust about 4 years ago. And he really wanted me to try and get some studies done. And when we were discussing it, I mentioned that I thought, surely you're not going to have any person with sepsis that will have an ABCDS score of less than 1.1. Surely. So surely that would be a lovely way of reassuring a paramedic that the patient did not have sepsis. So he came up with the idea of calling it a way to rule out sepsis if someone has an ABCDS score of less than 1.1. And if you had a nursing home with a flu outbreak, 30 people with high temperatures, all unwell, how are those staff going to decide which ones the GP should be first? Well, if they took a blood pressure and heart reading on each resident, obviously with a safe change, they could get the GP to see the ones with the highest score first. Makes sense, surely. And maybe is there a value which we would definitely call 999? We need studies for that. But if you had a value more than 2 and you felt unwell and you had a high temperature and you did it again, it's still more than 2, you probably wouldn't lie on the sofa like I did. Hopefully. Paramedics all seem to love what I meant to talk about, but they're not allowed to do this for until the study's been done. And A&E triage would be a lovely place. So I have tried to get a study done in Wythenshawe Hospital in A&E triage. Sadly, the trials coordinator was very helpful, but wanted me to try and get the funding myself. And I couldn't, on the funding application, I had to be able to put down various consultants that would run the trial. So rather than me, because I'm a carer, full-time carer, looking after a father with dementia, I can't really run the trial myself. Monitoring. So in my view, it would be interesting to have trials that monitored ABCDS scores while you're in hospital. So they've already monitored your news 2 score. Why not monitor that score as well and compare the two, see which is better? And certainly check it before they go home, because judging by the 2 patients that I mentioned, one sent home the day before, one sent home despite the high reading and then having to be readmitted, the current system of relying on lying blood pressures and heart rates is not ideal, in my view. Care homes, if your loved one is in a care home, and you want to make sure they are well hydrated and they're not going to have sticky blood liable to get a stroke or a heart attack at night, wouldn't it be nice if they had a weekly value done that would alert the staff whether or not they were drinking enough? And patients on chemotherapy, who maybe can't even make their temperature to alert you to sepsis, they could check their own readings every day, twice a day, and then phone Christie's and say, my goodness, my score's just jumped up, and it's still really high. I'm feeling pretty unwell. I haven't got a temperature, I'm feeling pretty unwell. And scores weird. So now, would you all now, if you were lying in bed, really unwell, temperature of 39, call the GP, the GP's got the blood pressure cuff on your arm, just check a lying and standing blood pressure. Would you feel confident to ask the GP to let you sit up at least, press the button one more time? You can't demand, it's not much demand, is it?
No,
but if you say, would you, I would really like to know whether my blood pressure drops when I sit up, or my heart rate shoots up, because I've heard it's a useful measurement to take. Even if you just say it's because you might be dehydrated, because they're used to that, and they're used to the idea that you might be at risk of fall. You know, so I want to make sure I don't fall when I go to the bathroom. Doc, you just check it when I stand up, because I don't want to fall and break my hip, or you don't want your loved one to fall and break their hip when they stand up. If you were being really bold when you've got the readings, if you're feeling too unwell to calculate it itself, and you can remember the abcds.co.uk, your GP is going to have a smartphone, and they could calculate it for you. Maybe. And yeah, that's it. So any questions?
Thank you, Stephen. That was really good. I'm just dropping a question from online. Helen asked a while ago, has any of this been published in a peer-reviewed journal, specifically about proving the figures?
Yeah, so I tried to publish an article in the British Journal of General Practice of my audit, and the editors loved the idea that said we can only publish big proper studies. So they said, write a letter. So instead, they allowed me to put an online letter with the data. But sadly, though, I didn't actually put the ABCDS scores in the letter. I made it quite confusing to read. I went too far, because I suggested the ABCDS scores could be used to adjust the new tooth score. And I only had about 400 words, 300 words. So I had to cut out tons of explanation. But it ended up being difficult to understand. It's still there, so you can Google it, British Journal of General Practice. And in a sense of peer-reviewed, well, the editors were happy putting it on there. And also I sent a letter to the BMJ, British Medical Journal, again, that they allowed, in response to another article on sepsis, and the editors allowed that to stay on as an online letter. It's just been, but sadly they didn't put that on in the paper version, even though earlier this year they published one of my letters in the paper version, but I didn't really on AI in medicine. I'm not really that interested in. Anyway,
just approximately in response to that, can you publish a series of case reports?
Well, the sad thing, I don't have the permission to write down all the patient's details. They died.